Hello, fellow students and professors. This is part one of two of the management of impacted teeth. What's an impacted tooth? An impacted tooth is a tooth which is prevented from completely erupting into a normal functional position. This may be due to lack of space, obstruction by another tooth, or an abnormal eruption path. Why teeth get impacted? Discrepancy between the arch length and the tooth size. Differential growth of the medial and distal roots. Retarded maturation of the third molar. Dental development of the tooth lags behind the skeletal growth and maturation. Incidence of extraction of permanent molars are reduced in the mixed dentition period, thus providing less room for the eruption of third molars, which is very relevant in the present day due to increased awareness of the population and dental treatment started early in childhood. Evolution theory, which suggests that humans with time uh, disregarded the need of the third molar because of the different dietary needs and dietary habits and types of food. The lack of development of jaw bones due to consumption of more refined food, which causes lack of functional stimulation to the growth of jaw. Why do we remove them? Maybe because of pericoronitis and pericoronal abscess, which is the most common cause of extraction of the mandibular third molar, or because of dental caries, because of that area is a high incidence rate because of difficulty of reaching good oral hygiene measures in that area, or periodontal diseases or orthodontic reasons because of the impacted teeth may cause crowding, or to facilitate orthodontic surgery, or the presence of odontogenic system tumors, or to manage unexplained pain, or because of resorption of root of the adjacent teeth, and to prevent jaw fracture. Contraindication includes poor systemic condition because uncontrolled patients with systemic disease are unsuitable candidates for this surgical procedure because complications may arise either intraoperatively or postoperatively. Hence, a proper history, physical examination are mandatory to rule out systemic diseases. And as age advances, the bone becomes more sclerosed, there are decreased healing response and greater bony defect. The procedure is more difficult and there is more likely of fracture to occur, and the surgical insults are less tolerated and the recuperation period is long. Damage to adjacent structures. Removal of the deeply impacted third molar is likely to damage the inferior alveolar neurovascular structure, resulting in permanent anesthesia. And also a questionable nature regarding the future status of a second molar. Extraction of a badly decayed, unrestorable second molar would permit the third molar to assume a functional position or at least serve as a bridge. Such cases have to be evaluated with consultation of the prosthodontist and endodontist. Deeply impacted third molars in patients with no history or evidence of pertinent local or systemic pathology should not be removed. Now we have the impacted third molar classification. The first classification is by the American Dental Association and the American Association of Maxillofacial Surgeons. It's classified by the dental procedure itself, into a tooth with overlying soft tissue, impacted tooth with partial bony impaction, and with complete bony impaction, or with unusual surgical complications. The second classification is the Winter's classification. We have based on the angulation, divided into the mesioangular, which is most common. It comes after that the vertical and horizontal, to the less extent the distangular, and to the least amount the inverted type. Then we have the Pill and Gregory's classification, which based on two relationships. First one is the anterior border of the ramus, where we have the class 1, which is sufficient space available anterior to the anterior border of ramus for the third molar to erupt. And class 2, we have the space available is less than the mesiodistal width of the crown of the third molar. And class 3, we have all or most of the third molar is embedded into the ramus. The second relation is to that of the occlusal line of the second molar. We have position A, where it is on line with the second molar. Position B, where the occlusal line is that below of the second molar, but also above the cervical line of the second molar. And position C, the tooth is impacted completely into the bone and below the cervical line of the second molar. Now we come to the preoperative planning for the extraction. Start by taking history, by taking the complaints of the patient and the medical and dental history. And after that, we have the extraoral examination, which examining the head and neck for signs of swelling or redness of the cheek, suggestion of infection, testing the lower lip for paresthesia, testing the lymph nodes, palpation for enlargement, and tenderness. For the intraoral examination, we have checking the mouth opening and general examination of the oral cavity and teeth and general oral hygiene, checking the third molar area, checking the state of the eruption, tissue overlying the tooth, and signs of pericoronitis. Also checking the condition of the impacted tooth and the second molar and the adjacent bone in the presence of cysts or tumors. This is done by radiographs, which either can be used periapical radiographs, occlusal X-rays, lateral oblique views of the mandible, or OPG, and also very effectively the CBCT and conventional CT scans. As we see, here are some examples of the X-ray, like the periapical or using the OPG or CBCT scans. We have the preoperative evaluation of the difficulty of removal. Prediction of the difficulty of the case allows to design a treatment that minimizes the risk of complication. As we see here, the criteria of it is position of the molar and the value of the difficulty and the relative depth and the relation with the ramus, and to have the score of it and to be easy, moderate, or difficult. Here are an example of also a difficult cases can be shown in the radiographical features, such as in the relationship of the inferior alveolar nerve and the impacted third molar, and the different kind of difficulties it can have, like darkening of the root, deflection of the root, narrowing of it, and there's the diversion of the canal, interruption of white line in the canal, and the narrowing of canal. Before we talk into the actual procedure, we have to talk about the surgical anatomy to remind ourselves of the different structures with the tooth. The location of it is situated at the distal end of the body of the mandible, where it meets relatively thin ramus, and it is embedded between a thick buccal alveolar bone and a thin lingual cortical plate. For the nerves surrounding that tooth, or close to approximately that tooth, have the lingual nerve, the long buccal nerve, and most importantly, the inferior dental nerve. For the vessels in that area, we have the facial artery and vein, which comes by close to the second molar area, and have the mandibular branches which feeds off into the muscles. Speaking of muscles, here are the various muscles close to that tooth. We have the buccinator muscle anteriorly, the temporalis muscle distally, the masseter laterally, and the medial pterygoid and mylohyoid medially. Now to the steps of the procedure. It started by anesthesia and incision and mucoperiosteal flap design and flap reflection, removal of bone, sectioning of tooth and roots, which is an optional step based on the case, and there's elevation, then wound debridement, wound closure, and post-operative follow-up. Starting with anesthesia, It is either done by local anesthesia, more commonly by an inferior level nerve block technique using an agent, most commonly lidocaine 2%, or depending on the case and the patient. Or we can use general anesthesia for patients who are difficult to cooperate, like mentally retarded, or there are two teeth extracted at the same time and on both sides. We need to use general anesthesia. Coming into the incisional and microperiosteal flap design. The most common used flap designs are the envelope flap and the triangular flap, which both start at the distally, right by the anterior border of the ramus, extending over horizontal cut, and after that going to the cervical area of the second molar. And to do the envelope flap, we continue by the step or to go down like this below to do the triangular flap. The complication may arise if we extend too distally, which may occur too distally, which may lead to damage of the buccal vessels, the temporalis muscle, and the buccal pad of fat. And if the incision extends more lingually, it may damage the lingual nerve. After that, we have bone removal. Conservative amount of bone removal should be done around the impacted tooth using handpiece and burrs, or to this extent, chisel and mallet. Some complications may include extraoral and mucosal burns, subcutaneous emphysema, fracture of the mandible by using chisel and mallet. Here are like a degree of bone removal based on the case. It might be slight or moderate or deep as shown in these examples here. The next step is tooth sectioning or root sectioning. This is an optional step based on the case. It is done by a specialist with good experience, and it indicates by deeply impacted tooth with resistance to elevation even after bone removal. And the advantage of using this step is reduction of operation time and bone removal needed. After that, we have elevation of the tooth using dental elevators. Some complication may cause luxation of neighboring tooth, maybe fracturing it, the crown, or fracturing the restoration. Soft tissue impingement by slipping the elevator, injury to the alveolar nerve, and fracture of the mandible by excessive force and temporomandibular joint dislocation. We have the last step of the procedure, which is wound debridement, and after that wound closure. As you see in the demonstration, after bone removal and tooth sectioning and root sectioning and elevation, there comes wound debridement. It is done by periapical curettage, and smoothing of sharp bony margins is done by profile or burrs, most commonly burrs nowadays. A thorough irrigation of socket with betadine solution with normal saline, and initial wound closure is achieved by placing the first suture just distal to the second molar, followed by sufficient number of sutures to get a proper closure. As we see in the demonstration, we have smoothing of the sharp bony margins and doing the sutures. First one distal to the second molar, and we have post-operative follow-up, which is the typical instructions after a surgical procedure. After placing the gauze in the patient mouth, we can let him use a pressure pack or ice applied to reduce the pain and the swelling of that area. We instruct the patient for a soft diet for 1 to 2 days. A dose of analgesic should be taken right before the effective local anesthesia wears off, and instruct the patient to avoid gargling, spitting, smoking, and drinking with a straw. And suture should be removed after 5 to 7 days, and antibiotics, if prescribed, should be scheduled correctly, and should be taken by the patient, directed by the doctor, until they are finished. Some complication post-operatively may be immediate, like hemorrhage, pain, edema, and drug reactions, or it may be delayed, like alveolitis, infections, and trismus. Thank you for watching.